among the patients who do not get the EV-302 regimen, so enfortumab vedotin and pembro, which regimens would you consider?
So I think that here, I would mention the role for the Checkmate 901 regimen, the GemCis plus nivolumab regimen. So this is still not US FDA approved, but we are anticipating approval, I guess, based on a regulatory review. So this is a phase 3 trial that looked at GemCis versus GemCis nivolumab. So this is only cisplatin eligible patients. And so this trial was positive. There was an extension of both PFS, hazard ratio 0.72, and survival hazard ratio 0.78. The key feature of this trial was the CR rate of 22% with GemCis nivolumab, which was about a doubling compared to GemCis. And the duration of CR was really durable with GemCis nivolumab. So median duration of CR was 37 months, suggesting that some of these patients might be cured. So this raises the possibility that in some patients, should we consider GemCis nivolumab if they're cisplatin eligible, especially if we think they might have a CR with cisplatin-based chemo or checkpoint inhibition. For example, those with lymph node-only disease come to mind, but this needs to be teased out in that trial to see who those patients are.
Yeah. Do we have any, biomarkers or even hint of biomarkers at this point to potentially select those patients?
Well, my favorite genomic biomarker for this candidate is ERCC2, which has looked really good in the neoadjuvant setting to predict path CR. In fact, it's validated for that. It's not used because patients without ERCC2 also can have path CR. But in this situation where you're trying to select between EV pembro and GemCis nivo, it could come in very handy. And so I think that biomarkers as well as maybe simple clinical markers like lymph node-only disease could be useful.
Yeah. And for patients who are cisplatin ineligible, would you consider an alternative regimen other than enfortumab, pembrolizumab?
I think it's a great question. And I think in countries where pembro EV may not be accessible or not authorized at least by the reimbursement purposes, I think the javelin bladder 100 paradigm is still very relevant. Patients may get carbogem followed by maintenance avelumab in the frontline setting if they have no progression on the induction chemotherapy. And I think that's a relevant study, phase 3 data with level 1 evidence. And we have now long-term follow-up data with confirmation of the overall survival PFS, and we actually have data at ASCO GU 2024 showing the long-term patient-reported outcomes and quality of life. These patients maintain their quality of life. There is no significant detriment despite the overall survival benefit and sometimes long treatment duration. Having said that, I think this is probably in patients who are, as you mentioned, do not have access to pembro EV. And I think that's a big discussion about, again, the global access disparities. I know, Karine, you're working on this topic and how you can have access to these regimens across the board, even with avelumab maintenance.
Right.
It took time to get the access across the board.
I mean, I will point out that in the EV-302 study, there were about 30% of patients who got platinum-based chemotherapy followed by avelumab maintenance, and the EV pembro looked better in that combination. So I wouldn't jump to a carbo-based regimen followed by avelumab, but as you say, for cisplatin ineligible or EV ineligible patients, I still think there's a role for that. It's still a standard of care, even if the numbers in these more recent studies look, maybe a little more compelling.
I agree, and again, I think the main, let's say, space or indication for javelin bladder 100 paradigm is in countries where EV pembro may not be reimbursed or available. But it's interesting to see, that in that trial, the EV-302, with this tremendous result, there was about a third of patients who got switch maintenance avelumab in the chemotherapy control arm. I would like to see it a little bit higher, but I think despite that, the difference was so significant that I think this does not take away of the practice implication.
Right. Even if 100% of them who are eligible got treated with avelumab, I'm not sure that would have equalized, the outcome would not have, I'm not sure it would have been the same as EV.
And to your point, real world data suggests that, maybe less than patients that we expected get maintenance avelumab, they have to maintain the progression-free state a few months later.
Right.
So it may not be 100% anyway.
But overall, I think, again, the data with EV-302 looks pretty impressive. I think across most subsets, and I think probably the panel would agree, we really see benefit for those patients, right?
Yeah, in all subgroups, you could see, they were all favored the EV pembro group. So whether you had liver metastases, regardless of your performance status, whether you had upper tract, which a third of patients in EV-302 had, the benefit was there for EV pembro in all of them. So it'll be exciting to get more information on this study as we get the paper published and things like that. But right now it's very compelling.
I agree. And I think in general with the panel,
And one question that I will ask Terry, if you know, we have not seen the paper yet, but I'm wondering how many patients in the chemotherapy control arm had access to enfortumab later. I assume it's a very small number.
Yes. Yeah, I don't think we know the numbers. Hopefully there'll be more data for that in the paper. But remember, EV302 is a worldwide study. Enfortumab, it was tested in through the EV301 trial, which was a third-line study after platinum, after PD-1. And it's only received regulatory approval in the US and subsequently a number of other countries. But when that EV302 study was run, very few patients had access. Even today, very few patients have access to late-line EV. So I don't expect that we'll see a high number there. But obviously, we need to see the paper come out.